Austin and I wrote a book, and it's called Signal: What Testosterone Levels Are Telling You About Your Health, and it is available for pre-order right now with copies shipping in June. Here's why we wrote it. The testosterone conversation right now is a mess. About a quarter of testosterone prescriptions in the United States are started without any lab work, and over half of men who meet criteria for low testosterone see their levels normalize on their own without any treatment. And at the same time, nearly 40% of men who are 40 and older who have low testosterone, only about 1 in 10 of them are actually getting treatment. So some men are getting medicated for problems that they don't have, while other men who would genuinely benefit from treatment, or at least an evaluation, well, they're not getting it. And everyone is trying to make decisions about testosterone, whether it's lifestyle, medication, or otherwise, without a clear framework for what testosterone even does. Signal is the book that we wrote to sort all of that out. It covers the physiology of testosterone from the ground up, how levels trend across the lifespan, and what has been driving them down at the population level over the last 50 years, with a surprising increase in the last decade. We get into what testosterone actually does to exercise outcomes and what exercise does to testosterone, because those are two different questions that get conflated constantly. There's a full section on female hormonal physiology rather than treating it as a footnote. We cover how to interpret labs when the testing itself is unreliable, lifestyle measures that can move the needle before medication enters the conversation, and a detailed chapter on TRT for the people where it is appropriate. This is the book we wished existed when we started out. Right now, you can pre-order the hardcover, the Kindle version, or bundle both together. And there's a pre-order special right now where you can add the Barbell Medicine testosterone course taught by Dr. Austin Baraki with a significant discount. The course is normally $124.99, and you can get it for $49 if you pre-order before June 17th, which also happens to be my birthday. So a little birthday present to me and help support what we do here at Barbell Medicine. Head over to barbellmedicine.com and pre-order Signal today. That's barbellmedicine.com. Look for Signal in the shop. Last episode, we walked through 2,000 years of people in positions of power, mostly men, telling women to hold back when it came to exercise, and the moment that the science finally corrected the record. Today, we pick up where that left off. What does menopause actually do to a woman's body? Now, most women in 2026 are getting told that it does everything. The weight, the belly fat, the bones, the heart, the brain. The fix is hormones, supplements, and obviously a proprietary protocol. The data tells another story. Menopause does some of it, for sure, but there are a lot of other factors in play, such as decades of detraining, imperceptible changes in eating habits, and age-related differences too. Today, we put numbers on the difference, the body composition, the cardiometabolic shift around the final menstrual period, what happens to bone, cognition, and sleep, and the biggest tool that we have to fight against what actually kills postmenopausal women, which isn't a hormone. Now, by the end of this podcast, the woman from last week, the one at the dumbbell rack holding the 5-pounders, she'll have a much clearer picture of what changed because of menopause, what didn't, and what she can do about both. I'm Dr. Jordan Feigenbaum, and this is the Barbell Medicine Podcast. And to help us walk through why 50 years of clinical advice told women not to lift heavy, what menopause actually does to your body composition and your brain, and the single lever that drops mortality more than any pill on the market, it's the second most handsome doctor in North America, Dr. Austin Baraki. What's going on, man?
Hello. I'm feeling good. This is a broad topic that we're tackling over the course of many weeks. And again, happy to help dive into it with the assistance of my better half once again.
That's right. And speaking of, if you're new to the show, two things. One, this is Barbell Medicine. We are physicians who've been in the health and fitness space for almost 20 years now, which is scary to say. We try to translate clinical research into language that a non-clinician can use, as well as, serve our clinicians in the audience. But number two, this is episode 3 of our menopause series. Episode 1 walked through the transition itself and the 20+ year correction on hormone therapy. Episode 2 covered the history, and today we talk about what actually changes during menopause. On the next episode, episode 4, that'll be lifestyle and training prescription, what to actually do. Each episode does stand alone, but if you have time, maybe pause this one, go back to episode 1. All right, Dr. Baraki, well, let's start out with body composition. And we'll begin with the question that women probably hear about most frequently, what menopause does to body composition. They've probably heard all sorts of numbers thrown around, and you have too, but the actual study that gives answers to this question most carefully is the SWAN body composition study. And I think the answer it gives is different from what most women have been told. So SWAN is an acronym, and it stands for the Study of Women's Health Across the Nation. This is a prospective group of about 3,000 women across 7 different sites in the United States, and they were enrolled in their early to mid 40s, and they were followed yearly with serial DEXA scans, which stands for dual energy X-ray absorptiometry, which is basically a fancy way of saying X-ray technology to tell you different body composition levels. And they did that for over 10 years. So this is from UCLA, Greendale, and colleagues, and they published their analysis in 2019. If menopause itself were the primary reason that women gained weight in the middle and during midlife, you'd expect body fat to start piling on quickly when the transition hits. You'd expect it to keep piling on across the postmenopausal years and account for most of what a woman gains between ages 40 and 60. Now, the SWAN data shows something different. Menopause does add something to this curve, but it's more of a small bump on top of a much larger trend that's more about aging and behavior across these years and across several decades. So, Austin, before I give the answer to what the study found, imagine this. A patient walks in, she's 51, perimenopausal, and she's gained 8 kilos over the last 6 years. Her menopause coach that she found on Instagram tells her that this is hormonal, that estrogen and progesterone changes are the reason, and that the only fix is menopausal hormonal therapy plus a proprietary supplement stack. Predict for me, going in, what proportion of her 8 kilogram weight gain would this study attribute to the menopausal transition itself?
Yeah, it's an interesting question because there are 2 ways of looking at it. One is how much of this weight gain is directly attributable to any degree of hormonal decline, or you could, if you wanted to take the extreme stance, like estrogen deficiency, so to speak, because that could be evaluated, that could be tested, and if true, then replacement or delivering, giving the woman that hormone back should either reverse that trend or should mitigate it from happening in the first place. So that is in fact a testable hypothesis. The other way to look at it, and this is the, I suppose, more charitable way. And if I were the person making those kind of claims, I might pivot and make the claim in this way to say, well, a lot of the changes that happen around midlife lead to a lot of unpleasant symptoms. And those unpleasant symptoms can then lead to a cascade of downstream consequences. So for example, having, hot flashes can make it really unpleasant to stay as active, to be outside, to be doing things throughout the year. The night sweats can disrupt your sleep, make it more difficult to recover, can make you feel terrible and have less energy and motivation to do the physical activity, might increase appetite, things like that. So there's a lot of plausible indirect ways that there could be some impacts here. But I think that if the question was, if she's saying purely directly hormonal, and the way we reverse it is by giving the hormones back, that is, to my understanding, not well supported by current evidence looking at this as far as the direct impact of the hormonal decline throughout the menopausal transition on total body weight gain, total body fat gain.
Yeah, I think you hedged that appropriately with the charitable take. So to me, there's really 3 predictions here possible. One would be if it's purely hormonal, you would predict, well, look, none of this is, or a very small fraction of it's going to be related to the changes in hormones. If it's indirect, you're allowing for a greater proportion of that. And then the third one would be effectively because the indirect changes are so large and cause all of these downstream behaviors and experiences and symptoms or whatever, then all of it is actually related to menopause. So you can't be wrong if you hedged it 3 different ways.
There you go. Yeah.
All right. Well, here is what Greendale found. The rate of fat gain doubled during the perimenopausal transition. A typical woman was gaining about a 1/4 kilogram a year before the transition, and that went up to about 1/2 a kilogram a year during it. The pattern held across every different ethnic group that SWAN tracked. The doubling lasted for about 3.5 years, basically the window around the final menstrual period, and then the rate slowed back down. So that totals about 1.5 kilograms of body fat and about 200 grams of lean mass across 3.5 years. And that's what menopause itself does to body composition for the average woman, based on the best study that we have, with thousands of women followed across their actual menopause transition. Now, if you compare that against the actual midlife weight curve or weight trajectory, well, the average U.S. woman gains 10 to 15 kilograms of total weight between ages 30 and age 60. The perimenopausal acceleration accounts for 1.5 kilograms of that on average, whereas the other 8 to 13 kilograms result from the interaction of aging, behavior, sleep, reduced activity, and dietary patterns that sort of predate and outlast the transition. So you weren't wrong because you've hedged it 3 different ways. So I'm going to give you full credit on that. But I think the next question is, where does the fat go, right? And subcutaneous fat, this is the fat that sits primarily under the skin. You can pinch it. It's generally less metabolically active. And so you can think of it as sort of maybe cosmetically something that you don't want to see. But I would view this as maybe the safest kind of body fat.
Agree.
Visceral fat is the fat that is packed around your internal abdominal organs. This is more metabolically active and more strongly linked to disease. Telling the two apart requires a CT scan because you can't really pinch your visceral adipose tissue. Sometimes this is called belly fat, but even that can be misconstrued where you have some subcutaneous belly fat, and this is deeper. You can't really see it. And so you use a CT, usually at the level of the lower spine, which can measure each kind of fat separately. So this study was run by Lovejoy and colleagues at Pennington Biomedical in Louisiana. They took 156 women in their 40s and 50s and followed them yearly for 4 years with serial DEXA, again, that's that X-ray technology, and abdominal CT scans. 38 of the women transitioned to postmenopause during the follow-up, and the remaining women remained premenopausal across the same window. What they found: only the women who became postmenopausal saw a significant rise in visceral fat, on the order of 40% over the years around their final menstrual period. The premenopausal throughout group, those who didn't transition, did not show a comparable visceral fat increase, whereas the transitioner group, that was 38 women, so the sample size is relatively modest, but again, they found that they had an increase in visceral fat, and this has been replicated in other studies with similar directional results. Now, I said earlier that subcutaneous fat, the fat you can pinch, is probably the safest kind of fat. Visceral fat, again, you can't pinch this, is associated with worse cardiometabolic outcomes, which is a fancy way of saying stuff related to your heart, related to how you process sugar in your blood, and things of that. And it is, to my mind, the second most dangerous type of fat. The first most dangerous fat is upstream in the liver. And so the way I think about this is that if your liver, which is not supposed to have much fat in it, gets full of fat, that spills over into the visceral fat compartment, again, packed around your organs. And if that gets full, it can go elsewhere to your muscles, for example, and get deposited there. And then, so those to me are the top 3 like most dangerous types of fat you can have. And then finally, in a distant fourth, is subcutaneous fat. Mm-hmm. That's my current understanding of how this thing works. And each of these sort of ectopic depots or storage sites, liver, visceral, intramuscular, all contribute to insulin resistance and subsequently cardiometabolic disease. For our purposes, the practical point is that the kind of fat menopause adds is on the wrong side, or the dangerous side of that overflow pattern. We discuss this more in our article and podcast on why your waist matters more than your weight, the science of visceral fat, and those are all linked in the description. But one interesting thing here is that you might not be able to pick this up with just a waist circumference test. While waist circumference is reliably correlated to visceral adipose tissue, it's still a crude measurement. And that's really the problem here. I think the R value, which basically tells you how well these things are correlated, where like an R value of 1 would be a perfect correlation. I think it's in the mid 7s, like 0.77 or something. So it's pretty good. But if we're just talking about like a couple 100 grams of change, mm-hmm. or less than that, your waist circumference may not actually change where this can actually increase. Visceral fat can actually increase, which can be problematic. Austin, is that something that you are actively measuring? Are you sending people for CTs or DEXA scans to check this out?
Yeah, I mean, I just had this conversation actually with a woman yesterday because we're in a weight management context. We're in the perimenopausal stage of life. And her first question was, what do you think my target weight should be? Mm-hmm. And she's been tracking her body fat percentage on these types of body composition scans. What do you think my body fat percent should be? And so I essentially had this whole conversation where I said, well, if the big picture goal here is, optimizing your health, we're thinking about health consequences and preventing complications down the line. We have a wide variety of different like measures and tests and things like that we can use. And your absolute body weight, not the most useful number to me. there might be a range of healthy weights where you could be, but of course you can have different compositions. Even body fat percent does not tell me a whole ton because it doesn't tell me where is that body fat. Is it around the hips and legs, subcutaneous compartments, generally healthier, quote unquote, or is it in the abdomen, in the visceral compartment, a little bit less healthy, or the much more concerning site? And so then I said, she'd been expressing some concerns because getting these body composition scans required like a fair amount of travel from where she lived. They were expensive. And so I said, well, a waist measurement is not going to be a perfect way to assess this, but it'll get us much closer. And so I would track a waist measurement and set a waist measurement target for you before I ever thought about setting a body fat percentage target for you or a single body weight target for you. I think that those are progressively less useful for predicting your health outcomes. And so, if the waist measurement was around 34 inches for this, for this particular patient, maybe aiming for a 31 inch waist measurement, I would at least feel more confident that we have substantially reduced her visceral fat if that change were to take place. Is it quite as good as maybe deliberately quantitating all of the visceral fat? No, but I also don't routinely do that in practice either. I use a set of other measures. So one could be waist measurement. The other could be other markers that would be reflective of the consequences of visceral fat. So what does the lipid panel look like? What do the triglycerides look like? What does the glucose look like? A1C or other markers of insulin resistance? Because if I see all of those things present, it's almost a safe assumption that there is some degree of visceral fat, liver fat, muscle fat contributing to those things. Whereas if all those things look fantastic, blood pressure, blood lipids, insulin sensitivity are fantastic, waist measurement is where I want it to be, there's really not too much more use of quantitating somebody's visceral fat with a CT scan. And in fact, there's a downside of, hey, I'm going to radiate you to tell me like, hey, you actually don't have that much visceral fat. We're doing great. So.
Yeah. The millisieverts are kind of not worth it.
Yeah, exactly.
I had the same conversation with a man. Same thing. He asked me, what should my target weight be? And I said, well, look, I'm happy to provide you with the target weight, but I have to also tell you it's maybe the least useful information because it doesn't tell me about your body fat, what kind it is, and where it's located. And so I started thinking about this hierarchy of like maybe the metrics that we can use here. Weight is probably the least useful.
Yes.
BMI comes right after that because it does now, you get to height. And we have some pretty good evidence for most groups of people that once you're above 30, that tends to be associated with carrying too much body fat, which certainly includes liver, visceral adipose tissue, and the muscle, but it's not perfect. Okay. And so then you can add like a waist circumference. You're like, okay, we're getting better. A body fat test, depending on what kind of body fat test, if it's not great, but like if it tells you how much body fat someone's carrying and where they carry it, I feel.
Yes. Yeah. Agree.
And then finally you get to like, we got a whole body CT and now we know where everything's at.
Well, I think that's also where, you've done an episode before on that body roundness index. And I think that it's trying to take these like, non-radiation involving non-invasive measures and try to turn them into some higher fidelity kind of version of the waist measurement that can maybe capture some of that a bit better. And we're all using different tools at trying to examine the same problem. If I have somebody whose waist measurement is already either borderline or in a concerning range, and they have other evidence of kind of metabolic consequences, then I already know what I need to know and we know what we need to do. Yeah. If all those things look great, then we also know where we're at and what we need to do. If there's some conflicting measures, like if somebody has a healthy appearing waist measurement, but they have evidence of metabolic, consequences, then there might be some value in trying to, look at things in a different way. So it's a matter of like using the tools to answer the primary question instead of like just wanting the data for the sake of it. Yeah.
So I basically told them, I was like, look, I want your body weight to be the number that has somehow arrived at this waist circumference and in particular this weight to height ratio, which is about 0.5 or less, but not less than 0.4.
Yeah.
And he's like, well, what do you think that's going to be? I'm like, well, that's, can be more challenging. But would recommend reading our article and listening to our podcast on why your waist matters more than your weight, because I talk about all of that there. So we know that menopause adds maybe the metabolically harmful kind of fat. But the bigger question, at least to me, and likely for most women, is what does it do to your metabolism? Right? Because you hear this all the time that, look, it's going to be different when you're older, especially when you go through menopause, your metabolism's going to crash and then you're going to store all this body fat, particularly in the abdomen. Well, we've got some data on this. Dr. Herman Ponzer's international team published the biggest study ever done on this question in the journal Science in 2021. They used doubly labeled water, which is the gold standard way to measure how many calories someone actually burns a day. And they did this in over 6,400 adults across 29 different countries. And importantly, they corrected for body size. So they could see if metabolism actually changes with age once you account for the fact that bigger bodies burn more energy. We also did a podcast with Dr. Ponzer. 10 out of 10 would recommend. He also wrote the book Burn, which I thought was pretty good. Mm-hmm. So if it were true that menopause slows metabolism, we would expect the curve of energy expenditure to inflect sharply downward during ages 45 to 55 in that window. But as it turns out, based on the most rigorous methods of measurement performed by Dr. Ponzer and his research group, it doesn't. Total energy expenditure, when adjusted for body size, stays relatively constant from about age 20 to age 60 or so. Now, after 60, it declines by about 0.7% per year on average, with no sign of a menopause-specific dip. Now, that study was not in just menopausal women or people during that perimenopausal transition, but there was a subsequent study in 2023 by Karppinen and their research group that looked specifically at resting metabolic rate in midlife women and confirmed the same pattern. What drives the decline in resting metabolism is aging with no real menopause-specific signal on top of it. So Austin, imagine a patient, she's 49, perimenopausal. She's gained 8 kilograms over the last 5 years. And again, she's been told by her menopause coach, this is all estrogen deficiency, and her metabolism has subsequently crashed as a result. She's asking you to prescribe menopausal hormonal therapy, specifically to reverse the body composition change. Walk me through that visit and what you actually say to her.
Yeah, there's probably going to be a familiar theme to some of our other patient scenarios, and this is less hypothetical than one that I see pretty frequently. And so getting a sense of where these beliefs came from and validating the challenge that this woman is going through. And really, I'm trying to see, is there any other compelling indications or justifications to prescribe menopausal hormone therapy that I'm seeing? Are there any other overt, like the textbook signs of estrogen deficiency? We went through a lot of those on our last episode, because there are kind of categories of symptoms. There are the things that are very specific, suggestive of estrogen deficiency that are very likely to respond to estrogen therapy. There are those that could be related, but can also be related to other things. And then lastly, there are those symptoms that are really unlikely to be related and are more likely to be related to other things. And I view this as kind of a spectrum of sorts. And I am very open to, again, I describe this as sometimes coloring outside the lines when it comes to, rigid clinical practice guidelines if I think something is safe and has a reasonable potential to benefit the person. But if they have rock solid, regular menstrual periods, no other symptoms whatsoever of estrogen deficiency, and purely the only issue that has happened is some weight gain over the past 5 years, I am gently redirecting the conversation, probably a bit away from menopausal hormone therapy as the key to improving that particular aspect, that we have much more effective strategies for this. Now, here's the other side of that coin, and somebody could plausibly make this case, is like, if the person is absolutely locked in on this as the only thing that they believe is going to help them, I really like the way that you have framed some of the study. I think you did this more for me than for our audience, where you set it up as terms of like, if this were true, what might we expect from this study? And then you look at the study results, right? And so if hormone therapy were otherwise safe in this person, we could say, like, if this weight gain were purely hormonally mediated, if that was a thing, and it is safe to try, and we wanted to give it a 3-month trial, 4-month trial, 6-month trial, what degree of weight loss should we expect to see? And then if we do that, and more likely the person does not spontaneously lose all of that weight, then that might go to challenge the hypothesis that this weight loss was purely hormonal. Of course, this assumes a lot of things about, how scientifically rigorous the person's mindset is towards this sort of thing. But I think in general, trying to do a comprehensive assessment of all of the potential reasons to prescribe menopausal hormone therapy, because if there are a lot of other reasons to do so, then I'm perfectly willing to do it, even if I don't think that I'm like specifically targeting this for weight loss in particular, because it may make the rest of the person's life easier. It may make it easier for them to adhere to the dietary changes we're recommending, or the exercise habits, or just might make their life less unnecessary suffering, which is all great. But again, if they have nothing else at all that I can pin on it, then I'm probably kind of trying to redirect and say, look, we have way more effective options. If we're looking to try something outside of just kind of quote unquote lifestyle alone for weight management, there are far more effective options that I would be way more confident would get you to where you want to be in a shorter time period than menopausal hormone therapy. Yeah.
I mean, this is the same way that I think about GLP-1s, for example, right? is that they're mostly a behavior change sort of instrument or tool, in that they help people who use them to do the things that they had likely set out to do multiple times in their life before and have yet to be successful. And so to the extent that menopausal hormonal therapy addresses any of these underlying drivers of the behaviors that happen associated with the perimenopausal transition, whether it's compromised sleep and subsequently that effect on appetite or willingness to participate in exercise, things of that nature, then yeah, we would predict a pretty good response from a weight management standpoint. However, if those things aren't really happening, and you're almost asking the patient for a reason to prescribe menopausal hormonal therapy, not because you're gatekeeping and because it's likely to be safe, but to the extent it's going to benefit them is directly proportional to, are they experiencing symptoms we know are well treated, well managed by these things versus something else. And so, yeah, if a person had that, it would make, I would predict, very good response. But if not, it's like, well, let's use a better tool because we have some of those if it's purely about the weight change. Does that kind of square with what you're saying?
Totally agree. Yep.
Let's talk about a concern that a lot of my patients bring to their clinic visits. Women often come in feeling frustrated because they are eating the same, they're maintaining roughly similar activity levels, but still struggling with their body composition. They feel like something has changed despite their best efforts. Because these changes seem to accelerate around menopause, it's completely natural to want to blame the hormones. But the best evidence that we have shows it's not that simple of a story. When researchers have followed women over long periods of time during the menopausal transition, we actually don't find rapid accelerations in muscle loss during perimenopause, especially in those women who remain physically active. The weight gain curve is actually steeper before perimenopause begins, which already suggests that those most dramatic hormone shifts that come along with menopause aren't the main culprit here. Now, what menopause does do is shift the location where the fat distribution ends up, so more towards the waistline and the belly as compared to the hips and thighs. And there's lots of theories as to why this happens, but the truth is that we are not 100% sure yet. The question of metabolism frequently comes up in this conversation, and metabolic rate is actually a target that's been rigorously measured. But declines in metabolic rate that are specific to menopause or hormone status haven't been found. There are some age-related declines that tend to appear at around age 60 on average, but menopause itself doesn't seem to accelerate these changes. So what can MHT do for body composition? Unfortunately, a lot less than we'd hope, at least directly. It doesn't directly increase fat loss or fat redistribution. What it definitely does do, however, is treat symptoms like hot flashes and night sweats. And when this leads to improved sleep, energy, and motivation, improved lifestyle habits tend to follow as well. And these are important downstream effects, even if indirect. On the topic of testosterone, we don't have strong evidence to prescribe it to perimenopausal women for body composition. There's actually paradoxical data from the SWAN study that would suggest that higher levels of bioavailable testosterone during the menopausal timeframe may contribute to central fat accumulation. And so this is not a tool that I reach for in this case. Ultimately, the changes that women in this stage of life experience are real, but they are not inevitable and they are not insurmountable. Treating your symptoms, protecting your sleep, and supporting physical activity often will make the most meaningful difference.
All right. Well, that's the body composition story. When we come back from the break, we're going to talk about what happens to cardiometabolic health, specifically cardiovascular disease risk. This podcast is sponsored by Factor. Between finishing our new book, Signal, work, and training, my schedule right now is not exactly relaxed. And when I get home late, cooking is just not happening. Relying on willpower is a problem that even I run into, but staying prepared with Factor is how I've been solving it. Now, Factor offers fully prepared meals designed by dietitians and put together by chefs. They're fresh, they're never frozen, and they're ready in 2 minutes. I've been leaning on the Muscle Pro collection because the protein is there and the macros fit my current energy needs. But they have over 100 rotating options, whether your goal is weight loss, whether it's health, GLP-1 support, and more. I love having this as an option to keep me on track, and if you can relate, it may be a great option for you too. Head over to factormeals.com/BBM50off and use code BBM50off to get 50% off and a free daily greens box, if that's something you're into. New subscriptions only. This is while supplies last through September 27th, 2026. See the website for details. That's factormeals.com/BBM50off. Summer's almost here, and that means once again, my wardrobe has to change. I want pieces that feel lighter and more breathable, things that are easy but still look put together. And that's why I keep coming back to Quince. They focus on high-quality essentials that feel and look great, breathable linen, soft organic cotton. These are well-made basics without the luxury markup. Their European linen pants and shirts are the perfect warm weather upgrade, starting at just $34. The t-shirts are soft and easy to wear, and their lightweight cotton sweaters are great for the cooler summer nights here in San Diego. And the best part, everything is priced 50 to 80% less than similar brands because Quince works directly with ethical factories and cuts out the middlemen. You're paying for the quality, not brand markup. And Quince goes way beyond just clothing. They've got custom furniture, ceramic cookware, premium bedding. It's the kind of brand you end up recommending to everyone for almost everything. So far, I've been really happy with all of the clothing that I've picked up from Quince. It looks great and it doesn't break the bank. That's Quince in a nutshell. Elevate your summer wardrobe. Go to quince.com/BBM for free shipping on your order and 365-day returns. Now available in Canada too. That's QUINCE.com/BBM for free shipping and 365-day returns. Quince.com/BBM. This podcast is sponsored by Figs. Now, if you work in healthcare, you already know that the standard issued hospital scrubs are mostly an afterthought. They don't fit well, they're scratchy, and they're perpetually on the verge of falling apart, which can lead to some embarrassing moments in the parking lot when you get out of your car and you're the fresh intern on the block. Not that I'm speaking from experience or anything. Figs designed their scrubs around what we actually do. They're lightweight, they're tailored so they fit like real clothes, and they're built to handle the kind of laundry abuse that comes with the job. They're also antimicrobial, which, given what we're walking around in all day, it's not a small thing. And it's not just scrubs. They've got a New Balance collab for footwear, compression socks for those long shifts, and outerwear for when the hospital administration decides that the entire building needs to be kept at 58 degrees. If I was still in the hospital, I would definitely wear these at work. And now Figs is offering 15% off your first purchase. Head to wearfigs.com and use code FIGSRX at checkout to get 15% off. That's wearfigs.com, code FIGSRX for 15% off. We talk a lot about training and nutrition on this show, but sleep is probably the variable that most people are underinvesting in. And the data on temperature and sleep quality is pretty compelling. If your sleep environment is too warm, you tend to stay in lighter sleep stages and miss out on the deeper sleep that your recovery actually needs. ChiliPad 2.0 by Sleep Me is a water-based mattress topper that lets you set your bed temperature anywhere from 55 to 115 degrees. It sits on top of your existing mattress, and the new version has a quieter dock, a larger water tank, and a nightstand remote for each side of the bed that detects when you get in and starts your sleep schedule automatically. If you share your bed, dual zones let each of you set your own temperature. No subscriptions, you buy it, you own it, and there's a 2-year warranty, and it's designed and assembled right here in the USA. Visit sleep.me/BBM to get up to $255 off your ChiliPad 2.0 with code BBM. You get free shipping, there's a 30-day sleep trial, free returns if it's not for you. That's sleep.me/BBM for up to $255 off your ChiliPad 2.0. One of the questions we get asked all the time is, what books do you recommend for people who are interested in coaching others or who are taking their training very seriously? And it just so happens that a friend of the show, Dr. Eric Helms, along with Andy Morgan and Andrea Valdez, just released the 3rd edition of the Muscle and Strength Pyramid books. Now, if you're not familiar, these cover the full hierarchy of what actually matters for nutrition and training, organized by priority, so you spend your time on the things that actually move the needle, and you get all of the science behind it too. Over 200,000 copies of the book have sold at this point, and for good reason. I read it, and it is excellent. So if you're looking for a great resource to have alongside our book, Signal, and you want to go deeper on programming and nutrition planning, this would be a great addition to your library. Right now, you can go to muscleandstrengthpyramids.com/BM10 and use code BM10 for 10% off. That's muscleandstrengthpyramids.com/BM10. Code BM10 gets you 10% off at checkout. All All right, we're back here on the Barbell Medicine podcast. And in the first section, we talked about body composition, metabolism, things that happen around the perimenopausal transition. But now I want to talk about this sort of cardiometabolic shift. So body composition is half of the story. And the other half is what's happening to a person's cardiovascular health, the lipid panel, the blood pressure, insulin sensitivity, all the things that drive cardiovascular disease over the long run. And there's one specific change here that's clearly driven by menopause, which is anchored to the final menstrual period, not just background aging. So in 2009, Matthews and colleagues published a study in the Journal of American College of Cardiology where they ran annual lipid panels on just over 1,000 women in the SWAN study that we talked about earlier. They used a statistical method that lets the rate of change in low-density lipoprotein, LDL. These are the sort of proteins that carry around cholesterol in your body. And so this statistical method lets you detect the rate of change in LDL at a specific time point. And they set that point at each woman's own final menstrual period, which let them separate the slow drift of aging from the sharper change that happens around menopause itself. In the 2 years around the last menstrual period, LDL cholesterol rose by about 5 milligrams per deciliter per year, and apolipoprotein B, those levels rose by about 3 milligrams per deciliter per year. If you don't recall what apolipoprotein B or ApoB is, this is the kind of detectable protein that's attached to what we think causes atherogenesis or heart disease primarily. And so just to put this into perspective, if you were unclear, if you were at risk for heart disease based on your standard lipid panel, an apolipoprotein B test would be more instructive because it captures all of your atherogenic load, or at least most of it. So in any case, across this perimenopausal window, low-density lipoprotein, LDL, went up by about 10 points, and apolipoprotein B, or ApoB, rose by about 6 points beyond what aging alone would have done. And the rise is concentrated in this sort of tight window right around the final menstrual period. Now, waist circumference, as we mentioned earlier, does tend to increase across this window, but it's too crude of a measurement to separate the visceral fat redistribution from general midlife weight gain. That's why they had to rely on CT data, which is ultimately impractical for most folks. The American Heart Association themselves put it the same way in their scientific statement on midlife women. The menopausal transition is a window of accelerated atherogenic lipid changes, but the magnitude is modest. So that's the picture on lipids. Next question is whether the rest of the cardiometabolic profile follows the same pattern, or whether something different is going on with insulin sensitivity and metabolic syndrome risk. So in 2008, Janssen again looked at the SWAN data and looked for the rates of metabolic syndrome, the cluster of high waist circumference, worsening lipid panels, high blood pressure, and high blood sugar that often travel together. Now, women in late perimenopause or early postmenopause had about 45 to 60% higher odds of developing these issues compared to premenopausal women of the same age, those who hadn't gone through their final menstrual period. But when the analysis adjusts for the visceral fat redistribution we just covered, most of that effect disappears. The hormonal change kicks the visceral fat redistribution into gear, and the visceral fat is what's actually causing the metabolic problems. I actually think if they would have measured liver fat directly, perhaps that would have been even more predictable, but harder to measure that on some level. In any case, the hormone change is upstream, and the fat is what's doing the damage. Austin, is this something that you talk about with patients when you're kind of, because you are such a good clinician and so thorough, and also very, very deeply into sort of cardiometabolic health? Is this something you bring up as like an add-on at a visit? Like, hey, and by the way, we need to measure your
directly
lipid
tie
panel
it into
like
as soon as we have determined that the person has crossed quote unquote the menopausal transition, then suddenly we need to do this because we have probably been doing it all along already. The situation where I tend to emphasize kind of the cardiometabolic risk assessment much more and just the overall degree of risk is when menopause is either early, meaning before age 45, or when the person is frankly having premature ovarian insufficiency or premature ovarian failure before 40, because those are much more substantial, long-term cardiovascular risks having it that early. And or if the woman has had prior history of significant obstetric complications. So that means like they had preeclampsia with one of their pregnancies or certain things like that, because all of those factors are things that are generally predictive of much higher, longer term cardiovascular risk. And the higher the risk, is for the person, that's usually when we treat them more aggressively. By the time we've gotten to quote unquote natural menopausal transition, if they're, going through that at about the expected time frame, we're monitoring all these things anyway. And I'm not necessarily rigidly tying them to menopause. There's already enough kind of catastrophizing messaging out there around what menopause does to you. And it's just, I'm looking out for your health and all the things that we need to be thinking about as we transition into the, through midlife is, your general health, your body composition, your physical activity, your bone density, and cardiometabolic function and things like that. So that's generally the way I approach it. I emphasize it much more explicitly when it is a much, much higher risk situation. Otherwise, it's just, I think, a good part of routine primary care.
Yep. Well said. All right. So that's the deal on insulin sensitivity, some lipid changes. But what about blood pressure? Now, blood pressure does tend to rise across midlife in women, also in men, but it similarly tracks aging and body composition more than menopause itself. So if you take an otherwise healthy 45-year-old, if you took everything menopause does to her lipids and blood pressure and run it through a 10-year heart disease risk calculator, it moves her absolute risk of having an unwanted cardiovascular event by about 1 to 3 percentage points. That's a real effect over time, especially when it stacks on whatever trajectory she was already on. And in the United States, it generally is not very good. A woman whose LDL was already creeping up before her final menstrual period is much more likely to cross a sort of treatment threshold during this window than a woman who started at, quote, optimal levels. The clinical implication here isn't that menopause flips her into a high-risk category overnight. It's just that the transition is the right moment for a full cardiovascular risk assessment because the lifestyle interventions that address these changes return the most when they are started early before the risk accumulates. We think that the risk is proportional to not only how high these risk factors are, but for how long they're elevated for. Now, you alluded to a specific case, premature menopause, especially before the age of 40. Well, this is formally recognized as a cardiovascular risk enhancing factor, and it does get treated differently. For natural menopause in the typical 45 to 55 range, the cardiovascular changes are real, as the American Heart Association's scientific statement makes clear, but they're not categorized in the way in risk calculators. So to be clear, natural menopause does affect cardiovascular risk. The reason premature ovarian insufficiency gets categorized separately is that the magnitude and the clinical implications are different, and we'll come back to that later in this episode. So Austin, the patient, she's 51. Her final menstrual period was last year, and her lipid panel shows that her LDL is 145 versus 125 2 years ago. Her apolipoprotein B is elevated. Her menopause coach told her that this is an estrogen crisis and she needs menopausal hormonal therapy to fix her lipids. What does that conversation look like?
Yeah, this is, I think the audience is maybe picking up on a common theme of the menopause coach catastrophizing menopause and saying that the hormones are going to fix everything. This comes up both in lipids, this comes up with bone density, this comes up with a lot of things. And as we've alluded to both between the last episode and already here, there are certain symptoms where we can feel very, very confident that estrogen therapy is very likely to have a substantial impact, arguably a bigger impact than any other treatment that we have available. The prime examples of that are the vasomotor symptoms, right? Very, very likely, or the genitourinary syndrome, delivering local vaginal estrogen. Very, very likely to deliver better effects on that particular symptom than anything else that we have available. This does not extend to every potential manifestation of the menopausal transition. When it comes to, lipid changes, for example, using menopausal hormone therapy for that purpose, less effective than directly addressing that risk factor. When it comes to bone density, let's say somebody has already established postmenopausal osteoporosis. Using estrogen therapy at that stage, less effective than directly treating the osteoporosis. Doesn't mean that the hormone therapy may have no role at all, but I think we need to put these things in their proper context and recognize the magnitude of benefit that is likely to be gained by using them, depending on the situation that we're in. And so this woman, again, just like the one who was concerned about her weight gain earlier, this woman may have some other reasons to use menopausal hormone therapy. She may have the vasomotor symptoms. She may have, some of the other justifications that may make it more strongly justifiable. But just if she has, again, no other symptoms whatsoever, no other concerns whatsoever, just a modest, I would say, increase in her blood lipids from an LDL cholesterol of 125 to 145, that itself I would not expect to be directly and substantially reversed to very low risk levels by offering her an estrogen patch, for example. There are still many other aspects of the conversation. I'm going to talk about all the things that we hammered on in our cholesterol article series and podcast series, talking about the dietary habits, making some smart substitutions, the physical activity, thinking about insulin resistance, family history, doing a risk assessment, and trying to determine, does this need directed medical treatments for the lipids in particular? Or is there some other secondary cause? For example, did this woman develop hypothyroidism? That's another reason that people's lipids can go up. Has she had her TSH checked? That can also make you feel tired. And again, this is a good example of why, if you are, for example, a quote unquote menopause coach, and default shade to people who identify as that, but if that is the extent of your expertise and your tendency is to view everything through the lens of menopause and hormone therapy, you are going to miss a lot of things because, again, thyroid dysfunction can look similar. Sleep apnea can look similar. Anemia, iron deficiency can look similar. Chronic infections can look similar. Autoimmune diseases can look similar. You have to have some degree of experience and expertise in recognizing, thinking about, differentiating all of these different things so that you don't lead people down the wrong path of cranking up hormone doses higher and higher and higher. Meanwhile, you're giving them the wrong hormone and they need a thyroid hormone replacement, or they needed an iron infusion, or they needed something else entirely.
This is not unique to the menopause space, though. I mean, you think about the
testosterone
in the manosphere and such.
Yeah.
If everything looks like testosterone deficiency to you, you're going to miss a lot of stuff. And so, the results are predictable. Every man needs these tests, and it's all about testosterone and estrogen or whatever. I'm like, could use a CBC to see if they're anemic.
Yeah, this is why generalists are good. In fact, that's my hot take.
Yeah, wow, really killing it. All right, so that's the story on cardiometabolic health. Now we get to bone, where the clinical picture and the underlying data have been out of sync for longer than just about any other area of women's health. What women have been told to do and what the data say they should do are diametrically opposed. So we're going to start out with the SWAN bone sub-study. So this is from that same research group out of UCLA, Greendale. They published another SWAN analysis in 2012, this time on bone, in just under 2,000 women followed across their final menstrual period with regular DEXA scans. Yes, this X-ray technology not only tells you body composition indirectly, it also, and perhaps to a more accurate degree, tells you bone mineral density. The pattern of bone loss across menopause isn't a straight line. It's slow in the years leading up to the transition. It picks up as a woman enters perimenopause. It peaks in the year or two around the final menstrual period and then slows back down within a few years afterwards. Peak annual loss at the lumbar spine was about 1.8% per year. At the femoral neck and the leg, about 1 to 1.2%. The cumulative loss across the 5-year transmenopause window was about 10.6% at the lumbar spine and about 9% at the femoral neck. The distal radius in the arm shows the same pattern, but at a smaller magnitude. Now, the problem here is that DEXA misses most of these sort of fragility fractures that women will have. Most fragility fractures in postmenopausal women don't happen to women who have officially crossed the line into osteoporosis on a DEXA scan. They happen to women whose bone density is in the osteopenia range or even in the normal range. The classic study here is from Series in 2001, where 82% of women showing up with fractures had bone density that wouldn't have qualified them for an osteoporosis diagnosis. Their T-score, which is the standardized score DEXA gives you, was better than the cutoff, which is, again, when people report studies on DEXA improving bone mineral density, DEXA measured improvement in bone mineral density, that's only half of the story. You also have to look, well, did they fall less or more? Did they have more or less fractures? Because that's what you really care about. The score is nice to have, but it's, on some levels, it's just a surrogate number. You want the actual clinical, the hard clinical outcomes. All right, so enter the LIFTMOR study from 2018. For decades, postmenopausal women with low bone mineral density were told to avoid heavy lifting. There was actually a 1995 recommendation to say, look, if you've got osteoporosis or osteopenia, do not load the spine because it's going to be a risk of fracture. And that, for generations of women, had put them in a bad place. The thought here was that fragile bones plus heavy loading equals vertebral compression fractures. Again, this is from the ACSM, the American College of Sports Medicine. They should have known better, but, it is what it is. Now, Belinda Beck's group at Griffith University, I believe this is in Australia, ran the trial in direct opposition to this. So this is the LIFTMOR trial. It included 101 postmenopausal women with low bone mass, and they randomized them to either do high intensity progressive resistance training plus impact training, which if you've listened to a few of our podcast episodes before, you'll know that this is from when they were doing jumping pull-ups and they landed from those with straight legs. So they either did that or a low intensity home exercise program. The intervention was 8 months of supervised training twice a week, about 30 minutes per session, and they did 5 reps for 5 sets at 80 to 85% of their 1 rep max on barbell exercises like deadlifts, overhead presses, back squats, plus the jumping chin-ups. Now, before any of the lifters at home, cry out, they did 5 reps at 85% of the 1 rep max? No way. Maybe it was a training max. These people are also new to exercise, so that it is possible they can do that. Let's just say that it was heavy, okay? Now, across 2,613 supervised sessions, the published total injury rate was 1 mild lower back strain that fully resolved. The person didn't miss any sessions. The intervention was safe in a population that the field had spent decades telling to avoid the exercise. Now, Austin, before we get to the results on what happened to bone mineral density, let's take the same patient that you would have seen 10 years ago, maybe even longer. She's 65. She has osteopenia, and she's been told for 15 years by her family doctor to avoid heavy lifting and stick to walking and Pilates. What would your priors have been? What would you predict the lumbar spine bone mineral density change in 8 months of supervised heavy lifting?
Yeah, I mean, I think that there's the traditional perspective on this, that is something that at best you might be able to slow the decline a bit, but unlikely to have a substantial effect. And then there's the side of things that we recognize based on our kind of experience working with people who train and seeing just how adaptable people can be. And that might lead us to a little bit more favorable of a prediction. But I think the overall, view in the medical community would have been that this is going to have a somewhat modest to even negligible effect, just based on, their level of knowledge and experience of what this sort of thing can do to, somebody's body.
Yeah, I agree. Perhaps even harmful. You would have predicted a higher injury rate, and you say, well, that's interesting, but while you got away with it, it still probably didn't do much.
Yeah, maybe predicted the trial would have been halted early because everyone, dissolved under the par.
That's right. Well, here's what the LIFTMOR study found. Lumbar spine bone mineral density rose 2.9% in the lifting group, and it fell 1.2% in the control group. Femoral neck bone mineral density held steady in the lifting group, while controls lost almost 2%. This is in 8 months. Again, this is in postmenopausal women with an average age of 65, with bone mineral density well below normal, doing deadlifts at 85% of their 1 rep max twice a week for 8 months, and they gained bone while the controls lost bone. So the LIFTMOR trial established that heavy progressive resistance training is not only safe in individuals with osteopenia and osteoporosis in postmenopausal women, but it also showed that it produces measurable bone mineral density gains in this population as well. Still, this trial did not address fractures, and thus you can't really say that, well, heavy lifting prevents fractures. We might predict, due to our biases, that would happen, but that trial to date has not been done. So the bone mineral density finding is reliable and seems to be rather large, but the fracture sort of inference from there is another leap that we just need to have studied. There's another study that repeated a similar type of setup. This is out of Germany. It's called EFOPS, which stands for Erlangen Fitness and Osteoporosis Prevention Study. I'm certainly butchering the name of that city, so sorry to all of our listeners who are near there. This is the longest controlled trial in the space. 16 years of follow-up in early postmenopausal women. They were doing multi-component exercise, which is a fancy way of saying they were doing a bunch of things. This included resistance training, and they compared that to controls who mostly didn't exercise. The results showed preserved lumbar spine bone mineral density in the exercise group and roughly 4.5% loss in controls. There were no major adverse events attributed to the exercise intervention across 16 years. Now, since Pilates is trending, I want to talk about it. In the MedX-OP trial, the same group that ran the LIFTMOR study compared their heavy resistance training program against a Pilates-based program called Buff Bones. And this was in 115 postmenopausal women with low bone mass. Across 8 months, the heavy lifting group gained 1.9% in lumbar spine bone mineral density. The Pilates group gained essentially nothing, 0.1%, which is well within the error bars of the test. And in the subgroup of women who were not on bone mineral density medications, so medications you can take to actually increase bone mineral density, Pilates actually lost a bit of lumbar spine bone mineral density, and whereas the lifting group gained the same 1.9%. The heavy lifting group also did better on functional measures, so back extensor strength, leg strength, and the 5 times sit to stand test that we sometimes use to screen for sarcopenia. Both programs were equally well tolerated, but the heavy lifting just worked much better. So I keep coming back to the same thing I've been saying about Pilates for years. It is fine as a physical activity, and if you like it, I love it. But it is not adequate for building bone and muscle and strength. And I think that people who have a pretty balanced view of this would agree. It is interesting to me when I get pushback saying that I don't know what Pilates is or Pilates does X, Y, and Z. And to that I say, show me. I'm open to the fact or the idea that Pilates would be sufficient to meet the current muscle strengthening guidelines, resistance training guidelines. But to date, every time that it's been investigated, it has fallen short. Austin, is that kind of your take on Pilates, or we can extend it to yoga or Tai Chi or water aerobics? I don't know. What do you think about all that?
I would not classify all of those things in the same bucket. Certainly water aerobics is one that, while again, a great activity for a lot of people, social environment, might feel good in various ways, is definitely the one that I would say is the outlier here in terms of actually essentially no skeletal stimulus is being delivered here, and we need to have something else as a form of true load bearing. For the others, I don't have extremely strong opinions for what I'll call the undifferentiated trainee, somebody who had been insufficiently active and is choosing among their menu of options of how they're going to enter the physical, space. If their way of introduction is going to be Pilates, and I feel like that might be the way that they get bit by some bug, and then we can build from there. Again, going from nothing to doing something is likely to have some measurable benefit, but is unlikely to have very, very large effect sizes on some of these things that we care about more, that there are probably better ways to achieve the goal. So I think there's the perspective of use the best tool for the goal outcome, but then there's also the more real world pragmatic approach of if the person is unwilling or unable to engage with that best tool, is there a slightly less best tool that they might engage with to start out with and kind of build from there? As far as specific outcomes, I have honestly outsourced many of my opinions on Pilates to you because you choose to fight those battles more than I do, and so I'll take your word for many of those things. But honestly, I just had this same conversation this morning with another patient and yesterday who are in these low bone density type situations, and so these topics do come up pretty regularly in practice. And so that's kind of how I lay it out. And I'm also getting a read on the person in the conversation of kind of when we've talked about quote unquote maximizers and minimizers before. Somebody who's highly motivated to do everything they can to use the best tool for the job. Okay, it's an easy sell to say we need to do some true, skeletal load bearing. Somebody who's much more of a minimizer and I'm struggling to get them to do much of anything, then I might see what entry point can I find to get them at least started. And then maybe we can build from there as they build some confidence, some self-efficacy, even they might start to enjoy it depending on the setting.
Yeah, no, I'm with you, especially this goes back to how we kind of prescribe exercise, generally speaking, to people. That's undifferentiated people who are kind of new to it. Whatever turns your crank, I'm here for it. Later, though, I am going to try to push you to not only meet the current physical activity guidelines, but to exceed them. And so the main thing first is yes, you're making this part of your lifestyle. You're excited. You're having fun. You're bought in. And then I need to kind of push you potentially towards doing something. This is the same way I feel about people who get bit by the powerlifting bug. Great. We are aligned. For whatever reason, we're all degenerates. We like powerlifting, but now I got to push you to do some conditioning, or the endurance athlete. I'm so impressed by you, but we got to do some lift. So it's not unique to Pilates, the or yoga or whatever else. The whole point is this is I don't think that they should be represented as this is enough. But that, again, that's not unique to Pilates. There's no single exercise modality that is enough. It's not CrossFit. Yeah, anyway, all right, we've beaten this horse a few times. All right, well, look, increasing bone mineral density is one thing, but to reduce fractures, we also have to reduce falls. Now, there was a Cochrane review done in 2019 that pooled 108 trials and over 23,000 community-dwelling older adults. Exercise reduced the rate of falls by about 23%. The strongest signals were from programs that combined balance training with progressive resistance training. Now, the balance training is, as you like to say, heterogeneous. There's not a single protocol, which is why none of our programs include the specific balance component. And further, The majority of our programs, what we recommend, have that intrinsically baked into it. There are freestanding exercises that do challenge your balance. And we feel like that adequately addresses this balance component while also building not only bone, but also muscle and muscular strength. So Austin, the patient, she's 64. She's postmenopausal. She had a DEXA scan last year that showed that her T-score was negative 1.4 at the lumbar spine and negative 1.6 at the femoral neck. Her primary care doc told her to avoid heavy lifting. She's asking, hey, should I be deadlifting? Walk me through that conversation, assuming this actually happens in practice.
I just had this conversation about 3 hours ago today, and I had another conversation of the same type yesterday morning as well with a few different patients. So pretty common, near daily sort of experience for me at this point. These T-scores are not in like terribly alarming territory. Obviously, this is more in the osteopenia range rather than immediately meeting criteria on their own for osteoporosis. Now, if the person had a history of fragility fractures, that would automatically upgrade them to that osteoporosis category, despite the T-scores. But the conversation starts out by just getting a sense of the person's understanding of their condition, and then also what might they be willing to do. They might be coming in with tons of fear and apprehension about deadlifting right off the bat, and a lot of times, in the conversation that I had earlier today, I actually don't tend to use the word deadlifting with people who are not already in the lifting space that often. I ask, like, are you able to pick anything up off the floor? Pickups, as we've talked about before. And so that was how I actually started the conversation earlier today. Can you pick something up that's like maybe a little bit challenging for you, something like that? And she was like, oh yeah, I can totally do that. So that was how I framed that conversation. Now, I don't think that, the way the question was framed should be deadlifting. I don't think everyone has to do this. There are a variety of ways to deliver an axial load through the skeleton, particularly through the axial spine, through the pelvis, through the hips, things like that. So for the individual that I spoke with earlier today, I asked if she was able to do essentially chair sit to stance, one of my favorite introductory exercises as folks get older. Was she able to do them, unassisted without using her hands? Was she able to do them while holding a load even in front of her? And she was able to do all of these things. So then we started talking about, how we might introduce an even heavier load, potentially across the back. She had access to a barbell in the home, whether a straight bar or a safety squat bar, whatever, something like that. And then whether she wanted to do it as a freestanding squat or whether she wanted to do it as a box squat, as something that's like a little bit more accessible and may have a little bit of less apprehension at the bottom of the movement, but can still deliver a challenging stimulus. So that was one example. And then just picking something up that's heavy off the ground. If her preference had been to start out with maybe more machine-based training, and we wanted to do that, I would similarly be able to pivot that way and think about things that could, deliver some sort of axial stimulus through the lower extremities, through the hips, through the pelvis. A little bit harder in that situation to deliver something through the spine when it's not necessarily freestanding, but there are some creative things that we've done before. So I don't kind of myopically focus on like, okay, the deadlift is the cure for this sort of thing. It is an option if you're interested and willing to do it. And I don't have apprehensions about prescribing them if the patient's interested in doing them based on a T-score of minus 1.4. That doesn't really concern me. I'm more concerned about, is the person training regularly? Is the dose appropriate? And then do they have comfort in guiding this on their own, or would they benefit from some additional supervision?
Yeah, I think this is just where our bedside manner just differs, because I would just send her the video of John Paul Sigmarsson deadlifting 1,003, where at the top of his lockout, he says, there's no reason to be alive if you can't do deadlift. Yes. And I think that drives
catering to slightly different populations, it seems.
Yeah, self-selected population. All right, so that's the story on metabolism, cardiometabolic health, and bone. Next up is cognition, because this is a big concern that women raise. Brain fog, for example, is the second most common complaint that patients bring up across the menopausal transition, outside of vasomotor symptoms, the hot flashes, and the night sweats. Now, patients often describe it as word-finding difficulties, trouble holding multiple tasks in working memory, and the feeling that thoughts arrive more slowly. Across the published literature, roughly half to 2/3 of perimenopausal women report cognitive complaints, depending on the group and the test being used. So the complaint is real, but the harder question is whether the subjective experience maps to objectively measurable declines in cognitive function. So again, we go back to the SWAN study, and they have a cognition sub-study that followed approximately 2,300 women in the SWAN cohort with serial neuropsychological testing. This test included verbal episodic memory, processing speed, working memory, and more. During late menopause, women's processing speed dropped a bit more than you'd expect from aging alone. The size of the drop was small to moderate. Memory took a similar hit, but even smaller than that. And once women got into early postmenopause, their trajectory went back to the normal age-related pace. So the dip during the transition didn't turn into a permanent deficit. Women got back on their sort of regular aging curve once they were through the menopause transition. Now, there's two caveats here. First, this is a population level finding. Individual women have variable trajectories at baseline. Some recover fully, some don't. Second, the SWAN Cognition substudy was observational, and it's not an RCT, right? It's not a randomized controlled trial where we have definitive sort of proof. But one of the major contributors to this sort of cognitive complaint is poor sleep. Specifically, sleep disturbance is one of the most disabling perimenopausal symptoms and underpins much of what gets described as, quote, brain fog. Now, two things happen to sleep across this sort of perimenopausal transition. First, vasomotor symptoms fragment sleep, particularly in the second half of the night when core body temperature rises and the awakening threshold gets lower. Second, sleep architecture itself shifts in a way that's partially independent of these vasomotor symptoms. Multiple studies have shown reductions in slow wave sleep. This is the deepest, most restorative phase of sleep. More frequent awakenings also have occurred, and longer sleep onset or sleep latency across this perimenopausal transition. Sleep lab data shows modest reductions in sleep efficiency in late peri and early post menopausal individuals compared to when people are premenopausal. So overall, a meaningful portion of perimenopausal cognitive complaints comes through sleep rather than estrogen acting directly on the brain, which means that the treatment should be directed at the sleep, not necessarily the brain. So if you treat the vasomotor symptoms, whether with MHT, so menopausal hormonal therapy in eligible women, or with non-hormonal options like we covered on our last episode, like fezolinetant or paroxetine or cognitive behavioral therapy for insomnia, you can improve sleep and you indirectly improve daytime cognitive function. That's an indirect cognitive benefit via sleep, not a direct effect of menopausal hormonal therapy or estrogen on the brain. So Austin, imagine this. A 49-year-old woman comes in with brain fog, night sweats, and broken sleep. She's anxious that her cognition is going. Her menopause coach told her that menopausal hormonal therapy will fix all of it. Walk me through how you talk to this patient.
Yeah, right at the outset, I think it's worth recognizing that this is going to be a longer term kind of clinical relationship, meaning I don't think it's reasonable to expect that we're going to just one and done, like nail everything and fix it all in a single visit. And I think from that perspective, there's a couple ways that you could go about this. My thought would be, to whatever extent the brain fog, quote unquote, may or may not be related to the hormonal changes, I am much more confident that the night sweats and secondary to that, the broken sleep are likely to improve if she's otherwise appropriate to receive hormonal therapy. And so maybe I just kind of pick my battles here and say, look, I'm very confident that we can help the night sweats, the sleep, by instituting some menopausal hormone therapy if it's appropriate for you. And then we can see how you do once you're sleeping better. And maybe the brain fog just like lifts at that point. That's one way to go about this. At the same time, though, we do need to be vigilant for other things that could be contributing so that we don't kind of kick the can down the road too far. And a perfect example, literally a visit that I had with a patient a couple hours ago, a different woman earlier today. So you can see how often I'm having these conversations with folks. This was a woman who was, in her mid 40s, had an IUD, so she was not having menstrual periods. So there's not really a sense of, where she's at in her menopausal transition. With that said, she had been experiencing some fatigue and some brain fog. She brought this up. Somebody started her on menopausal hormone therapy. She is not exactly clear on whether it's helping or not. She does not feel confidently that it's helping. And I don't really know where she's at in the menopausal sort of transition. Meanwhile, she has obesity. She snores. She's had witnessed apneas at night. She has extremely high risk for having obstructive sleep apnea. And so now I'm wondering, has this been untreated obstructive sleep apnea all the time, leading to non-restorative sleep, leading to cognitive functions, mood changes, all the other things that we know go with sleep apnea during the day? And the menopausal hormone therapy is treating nothing because it has not led to a meaningful benefit for her. And I don't even know whether she's even perimenopausal because she's not having any, menstrual periods or any other, no vasomotor symptoms, no hot flashes, no night sweats, right? So what did we end up doing? We're pausing the hormonal therapy, see how she feels, see if she develops any of those perimenopausal or menopausal symptoms, and then going to do a sleep study and see if nearly 100% certain she's going to have obstructive sleep apnea that will get treated. And then we'll see if we get things kind of on the right track. So this happens regularly. So to the scenario in this question, I would be not only very willing to treat the night sweats if that is a predominant symptom and concern that this patient has, but also thinking about what are the other things that can lead to this ultimate manifestation that is often described as brain fog for someone. Do they have any of these other things, the less specific sort of syndromes that we talk about so often, the sleep apnea, the thyroid, the anemia, the iron deficiency, all these other sorts of things, and checking off all those boxes along with this, rather than framing it as this is 100% exclusively estrogen deficiency and getting you back on estrogen is going to immediately take away all these things, because it happens all the time that doesn't actually end up panning out as well as people would hope. Sometimes it helps, but not always.
The menopause is going to be upset with you for telling big truths here in the menopause space.
Go seek care from whoever you'd like. That is okay.
All right. So that's the story on sleep. Let's talk about depression, because perimenopause is a sort of vulnerability window for new onset depression and for recurrence in women with prior major depressive disorder history. So one of the a couple of the classic studies here are the Harvard study of moods and cycles and also the SWAN mental health study, plus some others. They all converge at roughly the same point. There's a 2 to 4-fold increase in the odds of new onset major depression in late perimenopause compared to premenopause. This sort of window of vulnerability tracks the hormonal instability of late perimenopause, not really the steady state situation that we see in postmenopause. But the nuance about timing matters. A 47-year-old presenting with new anxiety, irritability, and or broken sleep deserves a differential that certainly includes perimenopausal depression. The clinical pattern of an SSRI prescription with no further workup, though, misses a potentially big part of the picture. SSRIs and other treatments for depression can work for these perimenopausal mood symptoms. So does MHT in symptomatic women. So does the combination. The right answer depends on the patient and their symptom profile. So new onset depression itself produces subjective cognitive complaints and measurable executive function decreases. A patient describing brain fog plus new low mood plus sleep fragmentation has 3 different issues that need a comprehensive workup, like Dr. Baraki alluded to. The other concern that comes up in this window is dementia, and that is a bit of a different question to my mind. Dementia in postmenopausal women is dominated by aging, vascular risk factors, education status, cardiorespiratory fitness, sleep quality, depression, and hearing loss. Now, the Lancet Commission on Dementia Prevention identifies 12 modifiable risk factors. Menopause isn't on that list. Now, that may be something that changes, but to date has not been on there. The wrinkle here is that premature ovarian insufficiency, so that happens under the age of 40, particularly when it's surgically induced, is recognized as a modest risk factor for cognitive decline and dementia. It's one of the indications for systemic estrogen replacement until the average age of natural menopause, but that's a different population than the typical perimenopausal woman.
And one of the really important things about premature ovarian insufficiency that you mentioned, when it's happening at that age below 40, you do not put those patients on menopausal hormone therapy. You put them on high dose because you are trying to give them the same high level of hormonal exposure that they would have had until that age of natural menopause. And then at that age, if you want to transition them to lower dose menopausal hormone therapy, that would be perfectly appropriate. It would be a mistake to take somebody who's, either naturally or surgically induced menopause at age 38 and put them on menopausal hormone therapy. That would be an error in under-treating them.
Yeah. But I think the broader question here that women want answered is whether menopausal hormonal therapy started around their actual menopause transition will protect their brain. Now, there are 3 major trials here that anchor that conversation. The first one is WIMS, the Women's Health Initiative Memory Study. This was published in the early 2000s. About 4,500 women aged 65 and older were randomized to one of 3 groups. One group got Premarin, that's an estrogen, and Provera, that's a progesterone. So they got both together. The second group got Premarin alone, and a third group got a placebo. In the combined estrogen plus progesterone arm, the risk of developing probable dementia was roughly double that of placebo. Now, that sounds alarming, but when you translate that into absolute numbers, it works out to about an extra 23 cases of dementia per 10,000 women per year. It's real, but not necessarily the catastrophe that the doubled risk suggests. And here's where the study design kind of matters the most. The women in the WIMS study were 65 and older. The trial did not test the question that patients in their late 40s and early 50s really want answered, whether starting MHT closer to menopause does something different. So the second study here is called KEEPS COG, the cognitive arm of the Chronos Early Estrogen Prevention Study. This was published in 2015. This one did look at the younger window. Almost 700 women aged 42 to 58 within 3 years of their final menstrual period were randomized to get Premarin, again, that's estrogen, transdermal estrogen, or a placebo for 4 years. The primary cognitive input was null, no difference. Neither MHT neither of the MHT regimens had a significant effect on cognitive function in this younger population. Mood, which was a secondary endpoint, did show some benefit in the Premarin arm, that's an oral estrogen. But the implication here is that whatever MHT does for symptomatic women in this age range, when it does anything, comes through mood and sleep, not from a direct effect on the brain. And the third trial is the ELITE trial, which stands for Early versus Late Intervention Trial with Estradiol. This was published in 2016. ELITE was designed to test the timing hypothesis directly. Over 600 women were randomized to one of two groups: women within 6 years of menopause, the early start group, and women 10 or more years out from menopause, the late start group. Both groups got either oral estradiol or placebo, with vaginal progesterone added for women who still had their uterus. The primary outcome was actually carotid artery thickness, a marker of cardiovascular disease, not cognition, but cognition was tracked as a secondary outcome, and there was no clinically significant effect in either the early start or the late start group. Taken together, what these three trials tell us is pretty straightforward. In younger women starting MHT closer to menopause, neither benefit nor harm to cognition was detected. The trials weren't powered to rule out smaller effects, so we can't definitively say that MHT does nothing, but we can say it doesn't really prevent dementia, at least not with a robust signal that many in the space are maybe claiming. So Austin, imagine this, the patient's 49, she's perimenopausal, she has new word-finding difficulties and trouble with her working memory. She's got broken sleep with night sweats and some new irritability. She's afraid she's developing early dementia. Her menopause coach told her this is hormonal and systemic menopausal hormonal therapy, MHT, will fix it. How does that conversation go?
Well, I got to be honest that the way you initiated that question, my hospital medicine brain jumped in and said a 49-year-old with new word finding difficulty, and I'm calling a code stroke on this patient. So I got to rewind and get back to the outpatient clinic, and that this is probably a more chronic sort of presentation that this patient has. So similar to our prior conversations, where the night sweats again being the most specific symptom that I can potentially modify and treat, and there may be some additional downstream benefits of that on sleep quality, on how she functions during the day. I think that contextualizing this based on the data that you have described so far, I kind of want to summarize my thoughts and general take on this whole area of cognition and the dementia prevention angle. So the first study that you pointed out was able to show us that among late starters of hormonal therapy, so in the older demographic who are already 65 and older, initiating hormone therapy at that age does not prevent the development of dementia. I think that we can say that with reasonable confidence. You're right that there's remained the caveat of starting earlier. The second study started earlier and did not find a substantial benefit over the 4-year follow-up period. And I think that caveat is worth noting, right? So, dementia is a very chronic sort of condition. And so is that the same as saying that it wouldn't have any detectable impact over a 20-year time frame? That remains possible. But the interesting thing here is if you look at the conversation in like the menopause space, they will say with a great deal of confidence that hormonal therapy, when started early, has a massive effect on lowering the risk of, cognitive deterioration in that way. I would love for that to be the case, yet we do not have strong evidence supporting that at this particular time. So again, while I remain open to these possibilities, at this point, we don't have the direct evidence to really show us that is likely to have such a huge impact. And to kind of compare this to one of the conversations we had last time, this stands in stark contrast to several other, as you pointed out, like modifiable risk factors for dementia that don't get nearly the attention that this does. So there's all this attention and emphasis on hormone therapy for dementia prevention, which lacks a great deal of evidence, while we're not seeing all of this around, the same degree of emphasis on cardiometabolic health improvements for vascular risk factors, on alcohol reduction, on, hearing loss, as you mentioned. There's even evidence on like the shingles vaccine has direct evidence on lowering the risk of dementia. And there's not this, if you were primarily concerned with a certain degree of benefit on lowering the risk of dementia, there would be many other things that you should be emphasizing at least as much, if not more, based on the magnitude of evidence that we have available. But that's not where it's at.
Could you imagine a Stacey Sims podcast that was like, you should get your shingles vaccine?
I think that would be the end of her, the end of her popularity in that way.
I'd repost.
Right. Yeah. So it's really interesting because if purely we're looking on just like comparative effect sizes, I would love for there to be evidence showing it. I'd be happy to recommend it for that purpose. I don't have that right now. And so I'm happy to treat for very well-established indications. I'm even happy to, again, color outside the lines and treat a little bit for off-label indications as long as it's safe with a plan for monitoring and to say, hey, is this helping? Great. Is it not helping? Okay, maybe we bail on this plan. Maybe we try something different. So that's usually the way I would go about it. But if somebody has no other concerns, no other complaints, and they just have word finding difficulty, oh my gosh, the differential diagnosis, like, again, I'm thinking of like this person could literally have a brain mass leading to word finding difficulty. And if it's like, oh, you just need estrogen, it's like, maybe not the right move when I think about the whole scope of differential diagnosis for, new onset neurological dysfunction. That could be a mystery case of itself. And I could go down a much longer list than, oh, this is likely a perimenopausal manifestation.
Yeah. If all you have is a hammer, everything looks like a nail.
Exactly.
Need some more tools.
Yeah.
Brain fog is an extremely common concern, and unfortunately, one of the most dismissed. Subjective cognitive concerns do correlate with objective cognitive testing. Also correlates with things like mood, anxiety, and vasomotor symptoms like hot flashes and night sweats. Now, does MHT help? We think so, but probably in an indirect way. The thought is that estrogen may help protect the brain, but only if it started soon after menopause when we believe that the brain is still responsive to it. This has been termed the timing hypothesis. By waiting years or decades, that window of benefit may have closed. The WIMS trial tested MHT in women with an average age of 71 and found no cognitive benefit. Was it too late, we wonder? So researchers designed additional studies to answer this question. The ELITE trial compared early versus late initiators of hormone therapy and found no differences in cognitive outcomes when they followed them after 2.5 and 5 years. The KEEPS trial, who enrolled women aged 42 to 58, similarly found no clear cognitive benefit. Even post-hoc analysis of the WHI showed a similar finding. So what we're left with is a bit of a mixed bag, including a growing list of underwhelming clinical trial results. Now, what we can confidently offer is effective treatment for vasomotor symptoms like hot flashes and night sweats. When those resolve, sleep improves and cognitive symptoms tend to follow. There's also evidence that vasomotor symptoms affect cognition through pathways other than through sleep disruption alone. So cognitive improvement may be a secondary benefit, but it isn't something that we can confidently promise as a primary outcome. Lastly, it's important to consider all of the other conditions that can impact cognition and not only focus on menopause just because that's the stage that a woman may be in her life. Conditions like anemia, thyroid disorders, sleep apnea, or evidence to prescribe, just to name a few examples.
All right, well, we've covered body composition, covered lipids, bone, and now the brain. Each of those is something that women are told to worry about, and each has a real but bounded menopause-specific signal. But none of them are what's actually going to kill a postmenopausal woman, or even the biggest predictor of how the next 30 years will go. Let's talk about what does. Using the U.S. National Center for Health Statistics data on causes of death in women aged 45 to 64, cancer is the leading single cause. In women aged 65 to 74, cancer remains the leading cause with heart disease a close second. From 75 onward, heart disease is number one. Stroke, lower respiratory disease, Alzheimer's disease, diabetes, and accidents round out the top causes. Osteoporosis isn't on the top 5 list at any age. The UK data is similar, but with one difference. Dementia and Alzheimer's disease became the most common cause of death in UK women in 2011. It's held that position since. Part of that is coding, just medical coding. But part is real. Whether deaths in advanced dementia get coded to dementia or downstream condition like pneumonia is variable and depends on the provider. Still, osteoporosis as an underlying cause of death is below 1% in every age sort of group. Hip fracture-related deaths are predominantly coded to circulatory or respiratory complications most often. So let's talk about the largest modifiable predictors of all-cause mortality, and that comes down to fitness. Fitness is the combination of a few different physical capacities, and two of them carry most of the mortality signal. The first is cardiorespiratory fitness, sometimes called aerobic fitness or CRF. That's the body's ability to deliver oxygen to working muscles during a sustained or prolonged effort. That's the thing you're testing when you run, bike, or take like a graded exercise test. The second is muscular fitness, which itself is split into strength, the maximum amount of force that you can produce, and power, the ability to produce force quickly. Both components carry independent mortality signals in the data, and the size of those signals is rather large. So let's start out by talking about cardiorespiratory fitness. So we go back to a study we've talked about a few times on this podcast. It's by Mansager and colleagues out of the Cleveland Clinic. They published a large retrospective cohort in JAMA in 2018, over 100,000 patients undergoing treadmill exercise testing at the Cleveland Clinic from 1991 to 2014. Now, these individuals were followed for an average of 8 years. And if you compare those with the top level of fitness compared to those with the bottom level of fitness, the people in the top group had roughly 80% lower all-cause mortality. That's the headline number. But two important things to note before we sort of run with this 80% number. First, this is observational data. The people in the study were patients referred for clinical exercise testing at the Cleveland Clinic, not a general sample of adults. So there's some selection bias there. Second, the 80% figure comes from comparing the very top of the fitness distribution to the very bottom. The effect between adjacent groups is much smaller. So a better comparison, perhaps, comes from a 2009 meta-analysis by Kodama, which pooled 33 studies and over 100,000 people. Fitness in that analysis was measured in METs, or metabolic equivalents, which is just a standardized way to express how hard an activity is, more specifically how much energy it uses while you're doing it. One MET is the energy that you burn at rest. Walking at a normal pace is about 3 METs, and it costs you 3 times as much energy. Jogging is around 7. Cost you 7 times as much energy as sitting at rest. So a MET is a unit that is sometimes used in fitness to be descriptive. How much energy is being used? How hard is it? For every 1 MET increase in somebody's measured fitness, all-cause mortality dropped by about 13%. So the lever here for cardiorespiratory fitness is real and it's meaningful at any starting point, but the 80% stat kind of overstates it. Even with those caveats, the fitness lever exceeds traditional cardiovascular risk factors in the same Cleveland Clinic cohort, including established coronary artery disease, mainly because low fitness has this predictive power in the short term, whereas established coronary artery disease is more of a long-term risk factor. In older adults, the death rate in the lowest fitness group was about 4 times the death rate in the highest fitness group, with most of the benefits landing as you move from the lowest level of fitness to the second lowest. So basically doing anything and to get you out of that lowest group is going to have the biggest benefit. So that's the story on cardiorespiratory fitness. But when it comes to muscular strength and muscular power, resistance training adds a partially independent signal. The first studies from MAMA 22 in 2022 in the British Journal of Sports Medicine, they pulled 16 studies together on resistance training and mortality. People who did regular resistance training had about a 15% lower all-cause mortality rate than people who didn't. Cardiovascular mortality looked similar. When resistance training was combined with aerobic training, the reduction was about 40%. The two interventions are partially additive. Then there's a question of what to actually measure on the muscle side, because strength and power are two different things. Strength is how much force you can produce maximally, also sometimes called low velocity strength. And power is how fast or how quickly you can produce that force, also sometimes called high velocity strength. A 2025 paper from the Clinimex cohort in Brazil compared the two head-to-head as mortality predictors. In about 3,900 adults aged 46 to 75 who were followed for a median of about 11 years, when comparing the lowest group on relative muscle power to the highest, the people in the lowest group had a roughly 6-fold higher risk of dying during the follow-up. Hand grip strength, the standard measure of muscle strength in this kind of study, was a much weaker predictor in the same people. So power, the ability to produce force quickly, looks like the more useful power measurement for mortality purposes, not raw strength. Now, if you haven't read this study, I thought it was pretty ingenious how they actually tested muscle power. It wasn't just how fast they could do hand grip strength. That would be kind of a goofy way, I think, to compare these things. It was pulling up on like a weight stack. Just like imagine like you're starting a lawnmower, but with both arms, and you have to rip a weight stack up to do so. That's how they did it. I was like, oh, this is like a high pull? Like is this like a sumo deadlift high pull or something like that? Yeah, pretty interesting. So no hate comms towards grip strength. Well, maybe some hate comms, because grip strength still carries a useful signal. And what you've probably heard about is, particularly if you listen to Atia's podcast, he belabored this point. The PURE study, about 140,000 adults across 17 countries, found that for every 5 kilogram decrease in grip strength, there was a 17% higher all-cause mortality. Now, you laid this out very eloquently before. Grip strength is this sort of integrated, high-quality readout of not just total muscle mass, but how well it functions, the neuromuscular function, and how everything is integrated together in order to work in a coordinated manner, which is why it predicts mortality so reliably in untrained populations. It kind of reflects the work of everything involved in that sort of system from brain to your fingertips. But it's also why the test isn't so good itself. When you train the grip directly, you can increase grip strength, but it has no correlation to improved mortality. And similarly, there's a strong genetic component to grip strength, as well as a strong mass component to grip strength. So how bigger people generally carry more lean body mass, whether that's an individual with obesity or an individual without. And so there's this sort of paradox here where just absolute grip strength numbers can be misleading, which is why we're not big fans of like grip strength testing. I don't think that you've ever handed a patient a grip strength dynamometer.
No, 0 times. I've subjectively assessed grip strength, but that's again more often when I'm doing a stroke evaluation and I'm trying to see if their one arm is weaker than the other acutely. But even that is not ideal.
Yeah, we did a whole episode on this. So if you want the deeper dive, check that out. It's linked in the description below. So to my mind, the biggest modifiable lever against the leading causes of death in postmenopausal women is fitness, both the aerobic side and the muscular side. Cardiorespiratory fitness and muscle power each carry independent mortality signals, and the two are additive and in some ways synergistic when you do both. The largest absolute benefit on the aerobic side comes from moving out of the bottom of the fitness distribution, so low levels of cardiorespiratory fitness, to the second lowest level. So going from sedentary to even modestly active is where most of the gain is. On the muscle side, the data points towards not only being able to produce a lot of force, which is strength, but also being able to do so quickly, which is power. Now, the training that builds both of those things is not unique to menopause. It's just engaging in progressive resistance training plus doing some conditioning. Now, the menopause content space, the menopause influencer space often has the priorities reversed. Heavy resistance training only, often with conditioning work framed as cortisol elevating, that you should avoid it. But the actual data is quite clear here. You should do both because the two together carry the largest combined mortality benefit of any modifiable intervention available. So Austin, the patient, she's 58, she's postmenopausal, she has been insufficiently active for the last 20 years, she's otherwise healthy. She has read enough to know that she should exercise, like most people, but she's overwhelmed by conflicting advice. What does that conversation look like?
Yeah, gosh, I feel like I just need to, get patients' permission to start recording my visits every day because I just had another conversation like this, earlier today. So it is interesting to recognize that she has read enough to know that she should exercise because she has that background information. She's coming in. I'm already staging her in like the kind of stages of change, behavior change sort of model. She's coming in already, curious, interested, asking questions. That already gets my foot further in the door than it might with many other patients who are either, they might be aware that it's good for you, but otherwise uninterested. She is at least interested, yet she feels overwhelmed. And so that's where having some professional guidance, some reassurance, helping her kind of dismiss with things that aren't worth being worried about, getting her maybe off of TikTok or social media, algorithmic media that is going to, exacerbate this problem, and giving her a set of like really, really quite basic, straightforward advice that can start to take her out of that like bottom quartile into the next one up in a relatively short time frame. Not that difficult to do. And so my first question is going to be whether she has any prior experience with physical activity in general? Any sports experience, any group class fitness things? Does she have any kind of social circle, anybody else that does this or anyone else who'd be willing to do it with her, to see what levers can I pull to improve, initiation and then adherence to this over time? Getting a sense of what her knowledge base is now and kind of tying that into what she might be willing to do. So some form of aerobic conditioning, whether starting out with walking and progressing to, jog walks, or progressing to stationary biking, or some form of, aerobic fitness based on her current abilities, her limitations, if she has any, like orthopedic or otherwise considerations that we need to think about. And what is she willing to do? What does she have access to doing? And then finding a way to set the volume and the intensity of that aerobic activity. The intensity we tend to set most often in folks like this with something as simple as a talk test. We want to get you to a point where you can, talk but not sing, and maybe speak in a couple word sentences but not be able to sing fluently. If you can, be able to belt out a whole verse of a song, it's still probably a bit too easy. That's a reasonable way to do it. If that doesn't resonate, then maybe introducing them to just a subjective effort scale and pushing them to the right degree of effort. That would be the way we do that. And then starting out with a very low volume, maybe two sessions a week, something like that, at a moderate amount of duration, say 15 minutes, 20 minutes, and then working that up with our current physical activity guidelines in mind, with a defined timeline of how long it should ideally take us to get there. That would be the way on the aerobic side of things. As far as strength training goes, I'll go back to my traditional sit to stance as the place where I start. Assess what is the person's current level of muscular strength and power by having them try to stand up again as quickly as they can, because that can introduce a little bit of velocity to it, and then see, can they do that loaded, especially if they can stand up already without the use of their hands. And then from there, that can be my launching point to explore what forms of loaded resistance training is this person able and willing to do. Are they going to have access and be interested in going to a gym? Is this going to be a home-based program? If so, what sort of loads do they have available to them, and how can those be progressed over time? If ultimately all I can negotiate is basically for somebody to do some loaded sit to stands and some pickups at home twice a week that can be loaded to a level that's, again, kind of hard, I'm okay with that as a starting point. And then again, a couple sessions a week of moderate intensity aerobic activity to where they can talk but not sing, I'm also okay with that as a starting point. That will be life-changing for this person. And then we can kind of progress it over time based on their abilities, based on their interests, based on their motivation, things like that.
Yeah. I think when people hear that, they're like, that doesn't sound like much, especially if you're listening to this and you're a coach or you've been training for a long time. And so you think about your own current training load or whatever. You're like, that doesn't sound like much. And yeah, that's the point. This person has not been gradually doing this for decade upon decade, which is unfortunate. But, while the best time would have been to start 20 years ago, the second best time is to start today. I think the disconnect is, though, when you start talking about optimal, right? And you're like, well, look, if we're trying to optimize all of the potential outcomes from exercise, the amount of exercise that we would really want to get you to work up to is probably more than you can do. Not because you're a bad person or there's some sort of moral hang up. It's like, dude, you don't have enough time. You mean you're not a professional athlete? You can't dedicate your life just to being in awesome shape? Unfortunately, that's the case for most people,
Yeah. And that's where the algorithmic media can really become a problem, because people either see amazing feats, which may be natural, may be chemically enhanced, or the messaging on it is really centered around optimizing and optimizer culture and maximizing, which is fine for somebody who really has the time, resources, and motivation to do that. But that's not most folks. And so that can be overwhelming, and why people can end up feeling like they have conflicting messaging, and why women are worried about, if I exercise too hard, it's going to give me cortisol belly and other nonsense like this, which is just not a thing.
No, I have no concern about somebody training to the point where cortisol becomes the dominant hormone, and now we've suddenly induced exercise-related Cushing's, for example.
Not a thing. Yeah.
Not a thing. Not a thing.
Yeah.
All right. Well, look, there's one more thing worth covering before we wrap up. Now, most of what gets marketed to midlife women as a menopause crisis is better explained by 20 years of declining physical activity. Now, when researchers put accelerometers on people instead of asking them how active they were, less than 5% of U.S. adults over the age of 40 hit the recommended 150 minutes per week of moderate to vigorous activity. For women specifically, those aged 40 to 49, only 3.4% hit this level of conditioning each week. For those 50 to 59, it's about 2.7%. Sedentary time averaged more than 7 hours per day. Now, when you compare this to the 42% of women who self-report that they are doing this much conditioning, you see where part of the problem lies. This is not unique to women. Men do the same thing. Now consider that only about 15% of women self-report that they're lifting weights. How big of a problem do you think that is? So this lack of exercise has predictable consequences. In the 2005 Baltimore longitudinal study of aging, 375 women were followed with serial measurements of their VO2 max over a median of 8 years. VO2 max is just a way to measure your cardiorespiratory fitness. So they found that aerobic capacity does not decline in a straight line. Rather, the rate gets faster each decade after 30. In your 40s, women lose about 8 to 10% of their aerobic capacity per decade. In your 50s, that climbs to 10 to 14%. The menopause specific piece is worth about 1% per decade, whereas most of the drop is aging plus the activity decline that we just talked about. For lean mass, in 2000, Janssen measured whole body muscle mass using MRI, which is very, very accurate, in 468 women. Skeletal muscle mass holds relatively steady until about age 50, then declines about 0.7% per year after that. Strength declines about 3 times faster. The piece that the SWAN data can attribute to menopause itself is about 200 grams of lean mass loss across the transition. Now, compare lifelong trained postmenopausal women against women of the same age who haven't been exercising. The catch is this kind of comparison comes from selected populations, masters athletes, and people enrolled in long-term studies of exercise. So certainly some survivor bias and selection bias. Lifelong exercisers tend to be healthier to begin with, more consistent with their exercise habits, and more likely to stick around for follow-up. So while these comparisons tell us what's biologically possible, they don't tell us what an average, insufficiently active woman starting fresh at age 55 is able to achieve. Now, with that caveat in mind, let's talk about aerobic capacity. For aerobic capacity, the Pollock studies followed masters endurance running women over 20 years. Trained women in their 60s had VO2 max levels of 45 to 55 versus age-matched sedentary controls at levels of 22 to 28. That's roughly a twofold difference. And the trained 60-year-olds in the sample had aerobic capacities that would put them in the fit range for women decades younger, right? If you look at the average VO2 max for women in their 30s, it's not even that high. It's lower. Okay. For bone, that EFOPS study we talked about earlier, at 16 years showed that lumbar spine bone mineral density dropped 4.5% in controls versus 1.2% in the exercise group over 16 years. It's not a gain, but a meaningful preservation over 16 years. And oh, by the way, their resistance training component was not very intense. For strength, a 2024 longitudinal analysis of competitive powerlifters showed something even more striking. The general population loses about 1% of their strength per year after middle age. But in this study, women over 59 who kept training and competing gained 2.5 to 5% per year. That's the opposite direction of what's supposed to happen. So a trained 60-year-old looks more like an untrained woman 15 years her junior across the measurements that matter. She isn't reversing aging as Father Time is undefeated and the biology that takes muscle and aerobic capacity away over time keeps doing what it does. But a meaningful amount of what gets lost between age 30 and 60 is recoverable, and the data shows how much. So Austin, the woman listening to this is probably somewhere in this window. Maybe she's 48 and she's just starting to notice changes. Maybe she's 58 and she hasn't been exercising for 20 years. Maybe she's 65 with a DEXA scan showing osteopenia and a primary care doc who told her not to lift heavy. Pull the threads together. What is the actual plan for any of them?
Yeah, not a fan of the advice from the primary care. So I think that initially seeking out some better guidance and expertise in this space would be worthwhile, whether the person has symptoms that are concerning to them. I don't even qualify them as perimenopausal symptoms because I'm going to say that they're going to be a wide variety of potentially specific and non-specific symptoms. Like seek out some, qualified expertise and guidance to help you work through it in a comprehensive way. I think that that's been one of the 2 consistent themes throughout this episode. Is that there are symptoms that you may experience. Some are more suggestive of the perimenopausal, menopausal transition that can be very effectively treated with, say, things like menopausal hormone therapy or non-hormonal options. There are also other symptoms that are maybe less suggestive and that those deserve their own, broad evaluation to make sure that nothing is being missed that can be treated more effectively in an alternative way. That's the first, I think, key theme is seeking competent expertise to explore the full breadth of these things that you may be experiencing. The other is this most powerful lever that you have pointed out and hammered on in the latter segment of this episode, the most powerful lever being fitness in general, which we break down into our cardiorespiratory component, which the prescription of which does not need to be terribly complex. It's more a question of sufficient volume where you're meeting certain targets on the talk test is fantastic. And then the strength training component, which can involve some both general strength or low velocity strength, can involve, if you like, some power training, can be something fun, can be something explosive. If you like, can involve something like pickleball, if you love that, something that a lot of folks are picking up these days that has numerous benefits, both physical, social, outside, lots of other things. And so I think that leaning into these two aspects is a great strategy for improving your midlife and later life health, targeting the biological components through medical evaluation and treatment when needed, psychosocial factors, as well as protecting your longevity, your physical function, your muscles and your bones by meeting these kind of physical activity guidelines that we've been hammering on for, as you said, better part of 2 decades. At this point, they have not changed that much over that period of time. It's more the uptake that we need to keep working on improving. So strength training, likely to be safe for the person in this demographic who's listening. Cardiorespiratory activity, there's likely to be some modality that we can find. And then to the extent you're experiencing debilitating, frustrating symptoms, if you're making progress or not making progress with your clinician, again, seeking out other opinions, specifically with expertise in this space, can be worthwhile for you.
Yeah. Well said. And I think, it's a recurring theme when we talk about exercise and dietary pattern change. There are very few situations that actually require, I don't want to say necessarily specialized knowledge, but a specialized approach. It's mostly the same. And when you talk about individualizing it to the person, meeting them where they're at, highlighting their preferences, their resources, what do they want to do, what's their motivation, this, that, and the other, that's universal. And so I hesitate to kind of come up with like a menopause specific program unless it were to sort of be taken up better, right? If it is branded as such, and I'm very clear that, look, while this is not specific to menopause, I roped you in and now you're going to get some real training. That's probably to the extent I could do it and feel good about myself and sleep at night. But I do have to, to say that one of my recurring issues when investigating various topics in this space is that there is not only just so much misinformation, but it's almost like siloed in a way where it's like, no, you need this specific fund of knowledge and this specific person. I'm like, that does not seem to be well supported by evidence. If there was, then, look, let's develop a new medical specialty, which I know it has been discussed, but I think that's mostly because OB-GYNs are kind of, there's a broad base of things that they have to address. And so, yeah, that might change. But anyway, Austin, is there anything you want to add for the woman listening to this who's somewhere in this window?
I think this is probably, to the extent that you are interested in detailed information on these episodes can potentially be quite dense, might need some multiple listens. If you are in need of additional opinions or expertise, again, we are available and happy to help by way of consultations, either the other Dr. Baraki or myself. We do this every day with folks. So yeah, happy to help.
A few things to take away from today. First, body composition. The menopause transition adds about 1.5 kilograms of fat and takes about 200 grams of lean mass over a time period of about 3 to 4 years. That is real, and the menopause specific piece is where the fat goes. Visceral fat goes up, and fat that doesn't get stored as subcutaneous or under the skin ends up in places it shouldn't be, which we call ectopic fat. First is the liver, then the visceral compartment that's around the organs inside your abdomen, and then in the muscle potentially. The other 8 to 13 kilograms, though, that's associated with midlife weight gain, that's mostly aging and habits that predate the transition and outlast it. Second, cardiometabolic. LDL and apolipoprotein B, or ApoB, rise in a narrow window around the final menstrual period. And that part is really menopause. The rest of the picture, though, blood pressure, insulin resistance, metabolic syndrome risk, well, that tracks with the visceral fat redistribution and aging more than the hormonal change. The hormones are upstream, the fat is what's doing the damage, and exercise can play a big role here. Third is bone. The biggest deposit window or opportunity window to build bone mass is in the teenage years through the late 20s, when peak bone mass is laid down. After 30, it's mostly about preservation. Bone loss accelerates sharply around the final menstrual period, with most women losing about 10% of lumbar spine bone mineral density across this window. The bone that you build by 30 is kind of what you have to draw down from. Now, for women with low bone mass, when they hit menopause, resistance training is still the standard recommendation. You got to do it. The 2018 LIFTMOR study established that heavy training is safe and effective in postmenopausal women with low bone mass, But for women with established osteoporosis with prior fragility fractures, pharmacotherapy enters the picture. There are many different medications that can be helpful, including MHT, especially as an option for younger postmenopausal women, especially those with vasomotor symptoms. Fourth, cognition. Brain fog is real in this phase, but it's mostly recoverable. It generally is the result of poor sleep, mood changes, and vasomotor symptoms, especially those that keep people up at night or disrupt sleep, more than estrogen alone acting directly on the brain. Menopausal hormonal therapy does not prevent dementia based on any evidence that we have, but treating the sleep, and particularly hot flashes that disrupt sleep, can help cognition indirectly. The fifth takeaway is about mortality. Cardiorespiratory fitness and muscle power are the two biggest modifiable mortality levers that we have, and they stack. The menopause content space mostly has this backwards. Heavy lifting only, with conditioning treated like it'll spike your cortisol and ruin you. The data says to do both. And the biggest single gain is going from doing nothing to doing something. And finally, menopausal hormonal therapy, or MHT. It is certainly the right answer for hot flashes, for the genitourinary symptoms, and for some bone protection in eligible women. But it's not really the answer for body composition, cardiovascular disease prevention, cognition, or mortality. Now, next week, we get into the actual prescription, what the training and nutrition and other lifestyle changes actually look like for a woman who's in this window, how they should start, how they should progress, and what to do when life gets in the way. I'm Dr. Jordan Feigenbaum. That's Dr. Austin Baraki and Dr. Loraine Baraki. This has been the Barbell Medicine Podcast. Thanks for listening. Austin and I wrote a book, and it's called Signal, What Testosterone Levels Are Telling You About Your Health, and it is available for pre-order right now with copies shipping in June. Here's why we wrote it. The testosterone conversation right now is a mess. About a quarter of testosterone prescriptions in the United States are started without any lab work, and over half of men who meet criteria for low testosterone see their levels normalize on their own without any treatment. And at the same time, nearly 40% of men who are 40 and older who have low testosterone, only about 1 in 10 of them are actually getting treatment. So some men are getting medicated for problems that they don't have, while other men who would genuinely benefit from treatment, or at least an evaluation, well, they're not getting it. And everyone is trying to make decisions about testosterone, whether it's lifestyle, medication, or otherwise, without a clear framework for what testosterone even does. Signal is the book that we wrote to sort all of that out. It covers the physiology of testosterone from the ground up, how levels trend across the lifespan, and what has been driving them down at the population level over the last 50 years, with a surprising increase in the last decade. We get into what testosterone actually does to exercise outcomes and what exercise does to testosterone, because those are two different questions that get conflated constantly. There's a full section on female hormonal physiology rather than treating it as a footnote. We cover how to interpret labs when the testing itself is unreliable, lifestyle measures that can move the needle before medication enters the conversation, and a detailed chapter on TRT for the people where it is appropriate. This is the book we wished existed when we started out. Right now, you can pre-order the hardcover, the Kindle version, or bundle both together. And there's a pre-order special right now where you can add the Barbell Medicine testosterone course taught by Dr. Austin Baraki with a significant discount. The course is normally $124.99, and you can get it for $49 if you pre-order before June 17th, which also happens to be my birthday. So a little birthday present to me and help support what we do here at Barbell Medicine. Head over to barbellmedicine.com and pre-order Signal today. That's barbellmedicine.com. Look for Signal in the shop.